Okay, so chapter 19 talks about instrument transfer and maintaining the operating field. And in this chapter, we're going to discuss the transfer zone. We'll talk about the fulcrum and tactile sensation. We'll talk about the different grasps, positions, and transfers of instruments for a procedure. We'll list the 8 rules of instrument transfer. We'll understand the instrument transfer modification and talk about and demonstrate how to maintain the oral cavity. We'll also talk about the equipment used in the treatment of the oral cavity and describe the techniques for moisture control and isolation. And we'll also discuss a little bit about expanded functions and what that means. So this starts on page 412 of your dental assisting textbook. And let's get started. So instrument transfer has to deal with the proper with instrument transfer. The proper instrument transfer occurs when the operator's view remains on the oral cavity, so that they don't have to look back and forth from a tray to the mouth. This will reduce the stress and fatigue, and it'll maintain the safety and comfort of the patient, all while making sure that production is increased with less motion. So efficient transfer allows for the operator to keep his or her eyes focused on the oral cavity and requires minimal movement of the operator's hands. A smooth transition occurs when the assistant is able to anticipate the operator's needs. So the transfer zone is the area just below the patient's nose near the chin. The fulcrum is the point of the rest on which the fingers are stabilized and can pivot. So whenever you hold an instrument in the patient's mouth, you're using either your pinky finger or your ring finger, or sometimes your middle finger, to help stabilize your hand, so that you don't have any shaky movements, and so it can help you control where you want that instrument to go. Tactile sensation refers to the feeling sensed by touch. The assistant passes and receives instruments with the left hand while working with the right-handed dentist, uh, as far as the transferring hand goes. If you're working with a left-handed dentist, the assistant passes and receives instruments with the right hand while working with that left-handed dentist. So the way an instrument is held influences how efficiently the instrument can be used. Selecting the correct grasp allows the operator control of the instrument, greater tactile sensitivity, and reduces fatigue to the operator's fingers and hands. So the pen grasp is on the left-hand side of the screen that you see there. And with the pen grasp, uh, the pad of the thumb and the pad of the index finger, with the side of the middle finger on the opposite side of the thumb, is where a pen is held. So that sounded a little confusing. So with the pen grasp, the way it's held is between the pad of the thumb and the pad of the index finger, with the side of the middle finger on the opposite side of the thumb. So very similar to the way you would hold a pen. With the modified pen grasp, it's similar to the pen grasp, but instead the middle finger is placed on top of the instrument, with the index finger. So along with the index finger, we have that middle finger that's placed on top of the instrument with the modified pen grasp. And you see here on the pen grasp, we don't have that. We have the middle finger below the instrument. So with the palm grasp, the operator holds the instrument in the palm of the hand, and the fingers grasp the handle of the instrument in the palm grasp. In the palm thumb grasp, the operator grasps the handle of the instrument in the palm while the thumb is extended upward from the palm. This is to stabilize the instrument when you're trying to use it. The reverse palm thumb grasp is a variation of the palm thumb grasp, which, for example, is used to hold the evacuator tip in the mouth of the patient. Failure to master these basic skills may result in injury to the patient, the dentist, or the dental assistant, and or loss of production for the office. Okay, so it's going to be very important to study all of these pen grasps, all these instrument grasps, and know how to hold every instrument. And we'll go over more of this stuff in lab as well. So when transferring instruments, the assistant will select the next instrument that is going to be used, and they hold it until the dentist signals the transfer. There are 8 basic rules for instrument transfer. Number 1 is the primary working end should be placed away from the assistant on the tray. This is so that when you grab the instrument, you'll grab it from the primary end first so that you can flip it around and it will be in the correct orientation when you hand it to your operator. Number 2, with straight shanked instrument, the primary working end should be placed toward the assistant. Again, this is so that when you grab that instrument and hand it to your dentist or operator, the orientation of the instrument is exactly as it should be, so that it can be worked within the mouth. Number 3, with hinged instruments, the beaks are placed toward the assistant. Number 4, you want to hold the instrument between the thumb and the index finger and the middle finger. 5, with pen grasp instrument hold, pick up instrument from the tray near the end closest to the assistant. And number 6, the assistant's hand is placed on the instrument opposite from the end the operator uses. This is so that you don't fumble around and the operator doesn't try to grab the instrument where your hand already is. So just keeping these basic rules will help to establish that kind of flow of instrument transfer. So the number 7 is to rotate the working end of the instrument until it is directed toward the dental arch being treated. And number 8, hold the instrument to be passed parallel to the instrument held by the operator. So by doing that, by holding that instrument parallel to the other instrument that the operator is already holding, you'll ensure that it's already in the correct orientation for them to let go of one instrument and to grab another. Again, this increases productivity and efficiency in the office. So there's a couple of different ways that instruments can be passed. There is a one-handed instrument transfer, and then also a two-handed instrument transfer. So with the one-handed instrument transfer, this is the most common. It saves time and allows the assistant to use the evacuator or air water syringe at the same time. So the assistant picks up the instrument to be transferred with this method, and with the same hand that receives the instrument, the operator is finished using. So the way they pick up the instrument is such a way that they pick up the instrument that the operator is using, and with one single motion, all in the same motion, you hand them the instrument they need next. With a two-handed instrument transfer, the assistant uses both hands for transfer. One hand receives the instrument from the operator, and the other hand passes the next instrument. So for those of you who have started looking at your instrument pocket guide, and you know what a Wheatl-stat is, that is a type of chisel. So what grasp would you use when using a Wheatl-stat? Well, for a straight angled instrument like a Wheatl-stat, we would use a palm thumb grasp. That is when, here, I'll go back to this one. So this palm thumb grasp is the way we would hand a Wheatl-stat instrument. Okay, so now we're going to be talking about instrument transfer modifications. So one of the most basic instrument transfers that you'll learn is the mirror and explorer transfer. So transfers of instruments must be modified when the size or weight of an instrument does not allow the normal transfer. The mirror and explorer transfer is performed at the beginning of the treatment, where the assistant picks up the mirror in the right hand and the Explorer in the left hand and passes them to the dentist when signaled. For the cotton pliers transfer, the cotton plier is transferred um, in two different ways. So it's transferred in two different ways depending on the type of cotton pliers that you have. If you have or are working with locking cotton pliers, those cotton pliers will lock automatically depending on how hard you press them. And so if you're using that, you can pass it from the opposite end, wherever the operator is going to hold them. If you're not working with a locking set of cotton pliers, then the way you want to pass the cotton pliers is to transfer it near the working end, or hold the cotton pliers near the working end. This is because that you'll need to be able to squeeze those cotton pliers, or squeeze on that cotton so that it doesn't fall out of the cotton pliers. Scissors are transferred as the assistant picks up the scissors at the hinge near the working end with them slightly opened. So when you slightly open the scissors, it kind of makes it so it's easiest for the operator to grab the scissor handles and start working with them right away. Dental handpieces are bulky and can be transferred with the one-handed transfer as the assistant picks them up near the hose attachment away from the working end. So one of the things about passing handpieces is if you're the only reason or the only way you would actually pass a handpiece to the dentist is if you're working with a front loading dental unit. Most of the time, it's going to be a side loading dental unit where the tray is going to be to the side of the dentist or operator, and they'll usually grab the handpieces on themselves. But if you are in an office where you're going to be using a front loading dental unit, then it's very possible that you will be passing handpieces back and forth. So if you're going to be passing a handpiece to the operator, you want to make sure you grab it near the hose, sort of like this person in this picture is doing, away from the working end. This is so that when you pass it to your operator, they have room on the handle to grab it near the working end and start working in the mouth right away. So with the air-water syringe transfer, the air-water syringe is transferred as the assistant holds the end of the syringe, covering the nozzle and tip with the palm of the hand, like you see this assistant and that person. So you want to grab it not by the working hand or the handle where the doctor is going to use it, but rather on the opposite end so that they have room to grab it on the handle there. So lighting is important when maintaining, So lighting is important when maintaining the operating field, and that's what we're going to be discussing next, maintaining the operating field. So with the lighting, you want to make sure that you position the light such that it illuminates the mouth or the oral cavity. The area directly involved in treatment must be kept clean, visible, accessible, and comfortable for the patient. These areas must be maintained by the dental team. Lighting allows the operator to see the oral cavity properly. The evacuator system is designed to remove fluids and debris from the oral cavity. The cool thing about the evacuator system is that it can remove lots of debris and very quickly and very forcefully. So a lot of the times the blood, saliva, debris from drilled tooth or a drilled tooth or drilled teeth will kind of flow into that evacuator. And so it consists of the hose, the evacuation tip, and the handle. And there are certain grasps and placements when using the evacuator system, and you want to learn these, and we'll go over them in just a minute. But also because the evacuation system is so strong and forceful, it's very easy to suck up patients' tongues or cheeks or even your doctor's finger. So you want to make sure that you're holding it correctly and that you're placing it in the mouth correctly. So now I want to go over a little bit about where to place the evacuator. So looking at this picture to the left, you can see that the tip is placed near the lingual surface, or the surface near the tongue, just distal to the tooth being worked on. The bevel of the tip is parallel to the lingual surface of the tooth. And notice that the tip is resting on the teeth, on the teeth in the maxillary right quadrant, so right in this area here. The picture to the left shows the evacuator tip in position with cotton rolls. And there's a cotton roll you can see in that patient's vestibule. Also, the handpiece and mouth mirror are in position with the air water syringe tip. The evacuator tip is positioned parallel to the buccal surface of the teeth and is resting on a cotton roll. So when we talk about buccal surfaces of teeth, remember this is near the cheek side, and we can see that this evacuator is parallel to that surface, and it's just kind of resting a little bit on that cotton roll. This picture to the left here shows the evacuator tip in position with handpiece and the mouth mirror. The tip comes just across the mandibular left teeth and is positioned between the lingual surface of the teeth and the tongue. So right between the lingual surface of the teeth and the tongue. The tip is parallel to the lingual surface of the teeth, and a cotton roll can be used to retract the tongue. So in this case, if you didn't use a cotton roll and you don't have that tip bevel just right, it's very easy to have that tongue go inside of that evacuator. Looking to this picture on the right-hand side, we can see that the evacuator tip is placed and the handpiece is positioned. So it's placed just here on the buccal side, and the handpiece is right here on the lingual side. The tip of the bevel of the evacuator tip is positioned parallel to the buccal surface. See that tip of the bevel? It's kind of hard to see in this picture, but there's another picture in your book on page 424. Let's see, where was I? And a cotton roll can be placed to assist in the retraction of the cheek, just so you don't suck up the cheek or the lip with that evacuator. So with this picture on the left, we can see that the evacuator tip is placed with the handpiece in position. And for the anterior facial tip placement, the operator positions the handpiece toward the facial surface. The evacuator tip is placed near the lingual surface of the maxillary anterior teeth, with the bevel tip rotated to catch the water near the facial surface, with the bevel of the tip rotated towards the incisal edge of the maxillary teeth. So depending on which direction that the doctor is placing that handpiece, you want to be on the opposite side, catching the water as it shoots out of the handpiece. So for this picture that you see on the right-hand side, the tip is placed on the lingual surface, so on the other side, or the tongue surface of the teeth. The mouth mirror and, the lingual, like I said, it was placed on the lingual surface out of the operator's way. So you don't want to place it sort of on the facial surface where the operator is trying to work, especially if they're working on that facial surface. Optional tip placement would be from the facial surface if they were working like on the other side of the mouth, or if they have that handpiece positioned in such a way that allows you to have room without getting in their way. So with this picture on the left side, we can see that the evacuator tip is positioned on the cotton roll near the facial surface of the teeth, or just right underneath the lip area there. The lip is retracted with the cotton roll, and the bevel surface of the evacuator tip is parallel to the facial surface. You see that bevel surface going parallel to those teeth there. This picture here to the right shows the evacuator tip positioned parallel to the lingual surface of the tooth. So we could see that this patient, or in these both of these pictures, the dentist is working on the same tooth, but we can see the different positions that they have the handpiece. So if they're working near the lingual surface, you'll put the evacuator tip on the facial surface. If they're working on the facial surface, you're going to put that evacuator tip on the lingual surface. So always just try to get out of the way, but at the same time, you want to be effective with the evacuator and making sure that you're keeping their field of vision clear. So the saliva ejector is a low volume evacuation tube, and its only purpose is to remove saliva or other fluids that don't have any solid debris. It's because the saliva ejector has this little braided tip that will only allow liquids to flow through and not pieces of debris. So if you're going to have pieces of debris, use a high volume evacuator for that. So the air water syringe emits water, air, or a combination of both. And its job in maintaining the operating field is to rinse the mouth and also to dry areas of the mouth that might otherwise be saturated with saliva or blood. There are several types of retractors that are used. And retracting the tissues is another function to increase the visual field when maintaining the operating field. And so one of the options to retract includes a mouth mirror or a rubber dam, or evacuator tip can be used, or a cotton roll or cotton gauze to retract tissues such as the tongue, cheek, or lip. So here in this picture, you can see someone retracting the lip with their finger, but they're holding the lip with a piece of gauze. That's just because sometimes it can get a little slippery, and the only way that you can actually grab onto it is to squeeze, which can be uncomfortable for the patient. So an alternative is just to use a piece of gauze to help you grab onto that tissue without having to squeeze so hard. So I want to talk about the isolite system now. This is kind of a neat gadget that's used to maintain, clear, um, and dry the field for the operator. So it provides isolation because it can retract tissues out of the way. It's connected to the evacuator, so it provides evacuation as well as a light source. The system includes a housing and control head and a one-time use mouthpiece. The control head includes a light emitter, a dual channel vacuum, and controls for both. So before the procedures begin, the device is connected to the dental unit's evacuation system, as well as an electrical source. And the isolite system can be used for many procedures, including crown and bridge procedures, fillings, implants, sealants, veneers, CEREC dentistry, which we'll talk about later in chapter 34, as well as laser dentistry, and sometimes in oral surgery, orthodontic, and periodontic procedures. So you can see that there's a vast array of different procedures that the isolite system can help with. And it's actually a pretty neat system. And it has the capability to reduce procedure times by more than 20%, just because of how well or effective it does these things here. So you can see a picture of one on figure 19-35 on page 428. And in that picture, it's kind of propped up in that patient's mouth. The cool thing about that also that I didn't mention before is it has a bite block kind of built into it. So not only does it help retract tissues, evacuate, and provide a light source, but it also is like a prop or something that the patient can rest on so that they can stay open without having to worry about it. So I think it's a really cool gadget to have. The only bad thing about the isolite system is the mouthpieces. They're only a one-time use. And if you're in an office where they're pinching pennies, and sometimes offices sometimes do that, it can be an expensive route, especially for really small, quick procedures like fillings or things of that nature. So there are other techniques for moisture control and isolation, and cotton rolls are another one. So cotton rolls come in various shapes and sizes, and they are used to isolate an area, rest the evacuator tip on, place materials with, and even serve as something on which the patient can bite on. Triangles are triangular absorbent pads that absorb the flow of saliva and provide surface for cheek retraction. So these are my absolute favorite method to control moisture because they are thinner and more lower profile, and in my opinion, more effective than cotton rolls, especially when you are um, trying to really make sure that you're isolating the two so that no moisture gets in that area. Again, every isolation control has its own uses. Cotton rolls are great, especially for placing in the vestibular area when working anterior teeth. But my absolute favorite for posterior teeth are these dry angles here. So now I want to talk about expanded functions dental assistants. So in many states, dental assistants can perform expanded functions with additional coursework, skill competency, and registration or licensure. The expanded functions are skills above and beyond the normal scope of dental assisting. When performing these skills, the dental assistant works alone, not under the direct supervision of the dentist, and the dentist delegates the expanded functions allowed in their state to fit the needs of their office. So these can include a numerous different functions, including but not restricted to the following things. So we expanded functions includes taking x-rays, placing and removing rubber dams, coronal polishing, taking study model impressions, placing sealants, making provisional or temporary crowns, placing bases and liners, taking intraoral photographs, performing orthodontic procedures without the dentist's supervision, removing sutures, and placing periodontal dressings. Okay, so virtually all of the things that we see here are things that we'll learn about in this program, but not all offices and not all dentists want all of their assistant doing all of these things. So like I said before, depending on the skill set and how much training that assistant has, you'll be doing some of these or all of them, or maybe just a few. So talking about dental dams now. So a dental dam can be used during restorative procedures to isolate the teeth required for restoration. So the dental dam allows for greater visibility and moisture control, and it also serves as a protective barrier, preventing the aspiration um, of restorative materials by the patient. So we don't want patients choking or swallowing things that we're trying to use in their mouth. And so a dental dam is one of the things that can be used to prevent that. So it isolates the teeth for restorative procedures. It provides greater visibility and accessibility, moisture control, protective barrier, and decreased aerosol exposure. So there are some contraindications or reasons why we shouldn't use a dental dam for some instances. So for patients with certain medical conditions like asthma or allergies, we may not use it. Concerns that the patient might have, like if they're claustrophobic or don't might not necessarily do so well when um, you know a balloon is placed over their face, or if they have certain conditions of the oral cavity that make it kind of impossible or difficult to use one. So what is a dental dam? So these are some of the things that is used to make it or to put a dental dam together. So one of the things that we'll have is this dental dam material. And that's that green sheet of latex or rubber that we see there. So it can come in different types. It can come in latex, nitrile, for those that are latex, have a latex allergy, and they have different strengths and sizes as well. The next thing is a dental dam napkin, which we see on item, it looks like item D over here. And you can see it looks sort of like this little paper or cotton uh, sheet of material that has a hole in the center that where the patient's lips would go. Um, and the reason why a dental napkin is used is just to provide a little comfort for the patient and to absorb any water, saliva, or perspiration from the patient. Dental dam floss and tape is what we see on, looks like item, I want to say J over here. It's hard to see from this picture, but the reason why we have the dental or the floss and the tape um, is because when we are fitting the latex over the tooth, if you floss it down, it'll catch into the embrasures and stick onto the tooth, so it doesn't move. The dental dam clamps are this little thing you see here, letter H. The dental dam clamp is placed on the anchor tooth, which is one or two teeth distal to the tooth or teeth being restored. The forceps are this apparatus that you see here, letter B. And what the forceps do is they hold on to the clamp. They have these little prongs here on the tip that have fit into the little holes in the clamp, and they aid in putting the clamp onto the tooth. The frame is what we see here, item C, and the dental dam frame or holder is designed to stretch and secure the dam in place across the patient's face. So it's got these little prongs or barbs on either end, and what that does is it holds that little latex piece on. So as you stretch it over the frame, you connect it or hold it onto the frame by those little prongs. The punch uses so the punch is this little almost it's this little hinged instrument here. It's letter I, and the punch is used kind of similarly to like a paper hole puncher, except that it has this little spear or stylus, the very tip that aids in punching a hole in the exact location that you need it to. And then we have a punching guide. And punching guides are usually stamped on. Sometimes they come in these little cardboard um, things that you can kind of push over the little piece of latex, but usually it's a stamp that you stamp right over, and it helps guide you to so that you know exactly where to punch the holes depending on which tooth you're working on. So before placing the dental dam on the patient, you want to educate the patient, let them know what it is that you're doing and why. Then determine the area to be isolated, um, and then dividing the dental dam into sections that you need. And then punching the dental dam correctly so that the hole is punched around the tooth or the correct teeth that you're going to be working on. So the patient should be told what the dental dam is for and what to expect when the dental dam is placed. The dental assistant trained in advanced functions can prepare and place the dental dam, and the area to be isolated should be determined, and then the dam will be punched, placed, and then held in place. So some common errors in preparing or placing these dental dams are matching the arch curve to the patient, cleaning and properly operating the punch table, and then spacing the holes correctly. So in lab, we will go over some of these common errors and how to go around them so that they aren't made in real life. So there's many techniques for placing. With practice, the dental assistant will be able to determine the placement technique that works best. So this is an advanced chairside procedure and must not be conducted unless properly trained in the techniques and procedures. So the dental assistant will either assist with the dentist with placement, or if the state that you're working in allows, you can place it yourself, especially if you know how and are given the correct training. So after everything is put together, your patient will look like this. So I know they look very comfortable, as comfortable as can be. But you see how that teeth that we're working on here are isolated from any saliva or any blood, or the tongue is kept out of the way. And also everything is covered, so in case you drop an instrument, it won't go down the patient's throat. So when you're placing it on a child, it can be a little bit more complicated. Basically, the technique is pretty much the same for both a child and an adult, but there are parts of the dental dam and the procedure that should be explained using the terminology that the child will respond to. So instead of using technical terms, what you definitely don't want to do with a child, you want to use terms that they would understand. For example, I'm going to put a little balloon over your tooth, or I'm going to use these little alligator clips to, to hold these things on. So just terminology that they would understand. You want to get to their level so that you don't scare them with these crazy terms. So when you're, this is that child looks like he's excited, right? So the child should be taught how to swallow and breathe with the dental dam in place. You want to ask them to breathe through in and out through their nose. That'll help with any choking or gagging if saliva pulls up in the back of their throat, for example. You want to ask them not to push on their tongue. You can see where this dental dam clamp is on this child. If you were to push that too hard with his tongue, it can pop off and the whole thing can come off. So just kind of educate your patient, gently instruct the small child on what to do and what not to do. So the child will require some proper preparation and teaching regarding what to expect, and how to breathe. So there's different alternatives for the full dental dam placement. There's things like quick dams, which are an oval piece of dental dam that has the border of flexible plastic. All of these different alternatives that we'll learn about in lab as well, they have their own uses, but they're not a one size fits all. And ultimately, the dental dam, or the traditional dental dam, is almost a fail safe. As long as you can work it correctly, um, usually it will do the job better than any alternative. So that's everything I have for you for chapter 19. Please let me know if you have any questions. Send me an email, or we'll talk in class. Thanks for listening.